Welcome to Flip Your Script, the vodcast from the American College of Lifestyle Medicine that is all about clinicians redefining care through lifestyle medicine. My name is Dr. Padmaja Patel, and I'm the current president of the American College of Lifestyle Medicine. I'm board certified in internal medicine and lifestyle medicine, and currently serve as the Chief Medical Officer of Nudge Health. Each episode delivers 5 key takeaways from leading experts, innovators, and practitioners on how lifestyle medicine is reshaping the future of healthcare. Through practical strategies and real-world success stories, we empower you to make a lasting impact in your organization and beyond. In this episode, we're honored to be joined by Dr. Jennifer Shalz and Molly Lynn. Dr. Jennifer Shalz is an internal medicine physician and medical director of St. Luke's Health System's Lifestyle Medicine Department. She earned her medical degree from Tufts University School of Medicine and completed her internal medicine residency at David Grant Medical Center, Travis Air Force Base. A board-certified lifestyle medicine specialist and a fellow of the American College of Lifestyle Medicine, she served as a major in the U.S. Air Force and later worked in the VA health system in Chicago, Portland, and Boise. In 2008, Dr. Shalz joined a radiation oncology practice to provide supportive oncology care and became certified in hospice and palliative medicine, serving as a hospice medical director. Since joining St. Luke's in 2011, she has helped establish the Lifestyle Medicine Department and directs programs that prevent, treat, and reverse chronic disease. She enjoys exercising, outdoor activities, cooking, reading, and traveling with her husband and 2 young daughters. Molly Lynn is a nurse practitioner with a diverse clinical background and a strong focus on integrative evidence-based care. She earned her BSN from Boise State University in 2001 and began her career as an RN in acute care, rheumatology, and clinical research. In 2011, she completed her MSN with a family nurse practitioner focus at the University of Cincinnati. Her clinical experience includes 1 year in family practice and 9 years in cardiology, where she worked extensively in a heart failure clinic. Molly earned her diploma from the American College of Lifestyle Medicine in 2018 and transitioned into lifestyle medicine in 2021. In 2022, she helped establish a dedicated POTS clinic where she continues to collaborate across disciplines to improve diagnostic accuracy and care pathways for patients with POTS, postural orthostatic tachycardia syndrome. Welcome, Jennifer and Molly. So great to have you as join today. How are you guys doing?
Great, and thank you so much for having us. We're honored to be here.
It's my pleasure. So first of all, for those who may not be familiar, can you please explain what POTS is and what inspired your decision to dedicate your efforts to this condition?
Absolutely. As you said, it's postural orthostatic tachycardia syndrome. So POTS is a chronic autonomic nervous system disorder that has as its predominant symptom orthostatic tachycardia, but actually the entire autonomic nervous system is impacted, and it is the most common form of dysautonomia. So we will be seeing this more and more, and it is actually has a lot of different symptoms. The most common symptoms that we see are actually a triad of lightheadedness, tachycardia, and presyncope, but often we'll see patients with headache and difficulty concentrating. So there's often a quintad of these as the most common symptoms. But as I said, it actually can affect the entire body, and patients can have a plethora of symptoms, and it actually makes it very difficult sometimes to diagnose. Now, the reason that this is an area that we decided to focus on with lifestyle medicine is that, first of all, we know that it is the symptoms can be responsive to lifestyle. And particularly, we actually have had a few of these patients in our cardiac rehab program over the last 15 years. Over the years, mostly adolescent patients. This condition affects mostly white patients, mostly females, 90% females, usually between the ages of 16 and 50. And we've had mostly adolescent patients through the years, here and there. And we've had a specific exercise program for them with some success. And but one of the triggers for this condition is actually viral. There are other triggers, sometimes traumas, and some other maybe hormonal triggers, but viruses are the biggest trigger. And with the onset of the pandemic, the incidence of POTS has gone up tremendously. And one of the physicians that diagnose this condition the most are cardiologists. In fact, 41% of the diagnosing providers are actually cardiologists. And our cardiologists, our colleagues within our service line, we're in the heart and vascular service line, actually came to us and said, we are seeing so many of these patients. We understand that exercise is beneficial. We really need some help. And could you look into designing an intervention to help us help these patients? And so at the time, we were hiring Molly Lynn into our department, and she very graciously took on this project. And she has done an incredible job designing this intervention that you'll hear about today. Thank you.
Yes. So Molly, how does a lifestyle medicine provider working within a multi-specialty team can support these patients in terms of managing their POTS condition and symptoms?
Mm-hmm. Jen laid it out that cardiology really came to us with this idea of, well, you can help because really what these patients need is physical activity, and we can refer them to cardiac rehab, and that's all they need to do. They just need to exercise. And it became apparent very quickly that it is not as straightforward as prescribing exercise for these patients. The autonomic system is influenced by sleep and stress and nutrition and physical activity, and all of those things interplay with how we ultimately came up with our current design. Mm-hmm. But they definitely, kind of oversimplified this idea that, yeah, you just need to give them an exercise prescription and they're going to feel better. So our department really has all of that at our fingertips in terms of support. So we were the ideal place for these patients to come to try and get some education and some support around behavior change and understanding of how they might best manage their chronic symptoms.
That makes sense. So in what ways could a focused 3 to 6 month lifestyle medicine program offer a more practical and effective alternative to a long-term clinic model for managing POTS, and particularly in terms of patient engagement or measurable outcomes and sustainability of overall care?
Yeah, I think our primary goal is to give patients the foundation of evidence that they need to treat symptoms and to raise their consciousness around what behaviors will ultimately help them feel better. The 3 to 6 month program design is really just that. It's to say, how do we create patterns in your life on a daily basis, and why would you create those patterns? And then moving forward, giving them resources like Dysautonomia International to help advocate for themselves when they return to their primary care. We're not autonomic specialists, and so what we're focusing on is really the evidence that we have at hand, and our own particular resources within our department and our community to help get them set up to continue to advocate for themselves.
What I would like to sort of add here, and maybe we need to emphasize as well, is that when I stated that there was an increase in the number of patients in our community with POTS, I wanted to, I guess I should have stated how large that increase was. At this time, there has been some data that 30% of people with long COVID seem to have POTS. And POTS is incredibly debilitating for people. In fact, many people have a very difficult time even going to school or working or even taking care of their families. And so this has really become an urgency in our community that they had nowhere to go, nowhere to turn. There was no one in the state of Idaho that really was offering them any services at all. And so this very, as Molly said, that there was a short-term intervention that we were offering where we were validating their symptoms and then giving them some empowerment with some skills to manage their symptoms that they could use even lifelong for this, what turns out to be probably a chronic condition where there's a waxing and waning of symptoms throughout their lives, most likely. Was something that we thought would be valuable. And we'll talk later about what the outcomes seem to be for the patients, but we did not necessarily, again, because we're not trained in autonomic neurology or that we're not specialists, that we thought we could give this at the very least. And we've been seeing some satisfaction with the patients.
Well, thank you for sharing that. So what is typically included in the initial group visit, and how does it set the foundation for individualized care?
Most patients, when they're diagnosed with POTS, come to our department with really vague information and a lack of understanding of what their diagnosis means. So they are diagnosed with POTS and they are told, drink more water, eat more salt, be more physically active and you'll feel better. There really aren't any discussions about POTS being a form of dysautonomia and what that means. So the initial group visit is to try to provide a foundation for those patients to describe how they got that diagnosis of POTS, what other things were considered along the way. Also what the autonomic nervous system is and why most patients have multiple symptoms that are difficult to explain, oftentimes symptoms that we don't have a clinical tool to diagnose. In terms of symptoms, those would be like brain fog or difficulty thinking clearly. That's a really common symptom for POTS patients that we don't have a test for. So that initial visit is really to talk about, here's your autonomic system. This is what your diagnosis could look like. It looks a little bit different for everybody. And then how can you effectively try to manage that? So the group visit goes through what medications are you prescribed that could potentially be influencing symptoms for the better or the worse. Supplements that you might be taking that could be causing symptoms, alcohol, caffeine. So we talk about anything that we're ingesting that could be part of our clinical picture. Then we go into really the evidence behind how do we manage POTS, and that's fluid and sodium, and 3 liters and 8 to 10 grams of salt, compression, physical activity, sleep, nutrition, all of those highlights. And at the very end of that visit, we talk about medication in terms of there really are no FDA approved medications for POTS. Oftentimes patients will need medication to help with symptom burden, and those medications will not ever replace their lifestyle behaviors around managing their symptoms, but that they could be additive to help with symptom management. So that group visit is about an hour long, and we try to really offer validation in relation to this experience being oftentimes debilitating and withdrawing them from things like social scenarios, work, family. It really can be quite isolating.
And what does the group size look like typically?
We have 6 patients per each group visit.
Okay. And how does follow-up care through individual visits personalized treatment plans and referrals ensure that you have this comprehensive management and continuity with the primary care provider who's referring patients?
Yeah, after the group visit, we ask them at the end of that visit to kind of evaluate where they're at with their lifestyle behaviors and to set small specific goals. For example, if you're drinking 40 ounces of water every day, we want you to try to increase that to 60 ounces, and with the ultimate goal of 80 to 100 ounces a day. So we ask them, set some small specific goals around the advice that we've given you. That individual visit is really to dig into what are you doing on a day-to-day basis? What are the barriers to you getting in fluid and sodium? How are you getting in fluid and sodium? Are you measuring it? And then a big part of that follow-up visit is about physical activity, meaning how do you respond to physical activity? A lot of the long COVID patients have post-exertional malaise, and adding physical activity in the setting of post-exertional malaise is very thoughtful and nuanced, meaning any increase in activity that provokes worsening symptoms should be avoided. So for some patients, the initial goal is pacing. And most people don't realize that everything we do requires energy. So taking a phone call, stopping on the street to talk to a friend that you run into at the grocery store, those types of things for people with severe post-exertional malaise require thought. So on the spectrum of I have severe post-exertional malaise and I have to be very intentional about even brief social interactions, to my post-exertional malaise is fairly mild and I am doing well at pacing, you have to get a good idea of where they're at. Once you know where they're at with their post-exertional malaise, if they're experiencing that, then it is about adding activity intentionally. So for POTS patients who are highly symptomatic when they're upright, they can start with a lying down exercise routine with gradually moving to seated. And then for some, perhaps they're going to move to upright exercise, but that's going to vary from patient to patient. The two protocols that we refer to for advising for physical activity is the CHOP protocol, which is the Children's Hospital of Philadelphia, and they provide really clear information to the patient regarding their rate of perceived exertion and how to very gradually increase their activity level. And then the ADAPT protocol through University of Utah is also available, and that's online. And theirs is the same approach in terms of very slow, gradual, intentional addition of physical activity without exacerbating symptoms. Some people will do better in pool therapy because the water offers compression. So in terms of determining kind of where somebody's at with their fatigue level and their POTS, and if they have post-exertional malaise, it may be about PT and pool therapy before they start a protocol like CHOP or the ADAPT protocol. So we try to be in that first visit very intentional and tailoring it to where the patient is at. If there's somebody who has significant GI symptoms with increasing their fluid intake, or they've had bariatric surgery, then getting to 80 or 100 ounces a day may not be feasible for them. So how do we maximize their intake to the most that is tolerable for them?
Yeah. Jen, anything you would like to add?
Yes, I think I would like to add that we also have during these visits, we will be referring to our other multidisciplinary team members as well. So we have an occupational therapist as well as an exercise physiologist who are both interested in helping to manage POTS patients and are very interested in helping them with their exercise prescribing and guidance and helping them with increasing their activity. And also, Molly probably was going to talk about too, the follow-ups include talking about medication trials. And she does start medication trials at some point and then does follow up on those as well. And so those also are very helpful along with the lifestyle, for sure.
Agree. Yeah, that first visit, Jen's right. There's really a lot of thought into what other resources are going to help this patient in relation to, do they need cognitive behavioral therapy for insomnia, PT, OT? If they are somebody who was well informed about their diagnosis and they have been utilizing fluid, salt, compression, physical activity, we typically ask them what is the most helpful for them. So, for example, if somebody has great benefit from compression and they report a lot of symptoms of blood pooling, then that would be a time to maybe consider a vasoconstrictor like midodrine and start it. I think most patients are going to need a combination of lifestyle and perhaps PRN or daily medication to help with symptom management.
Most common medications are likely going to be like beta blockers for some of the tachycardia symptoms like palpitations. Midodrine is one of them, maybe even fluid expanders for some of the orthostatic type symptoms. And just a note, I don't think I said this right in the beginning, but orthostatic hypotension is not part of this phenomenon. This is orthostatic tachycardia alone without orthostatic hypotension. So sometimes we are using, those medications that are going to take care of that tachycardia alone. And then sometimes SSRIs and other even more novel medications. But as Molly was saying, that none of these are FDA approved for POTS yet. And many of these are going to be a kind of a trial.
Yes. And I would say one of the other myths around the POTS diagnosis is that you have to have fainting or syncope to have a POTS diagnosis. And POTS is a feeling faint disorder, but not a fainting disorder, although about 30% of POTS patients also have a history of syncope. So that's something to consider. And also when thinking about orthostatic intolerance, even if you're not able to quantify it as POTS, it would still be appropriate to treat them with fluid salt compression. And I think there's a large number of patients who have typical symptoms of orthostatic intolerance without a clear diagnosis that kind of get minimized and not really given appropriate advice. So whenever appropriate, increasing fluid salt and compression could also help those patients.
Wonderful. Now tell me, what outcomes do patients report after participating in this intervention, which focuses on lifestyle? And how do these impact daily life, school, and going back to work?
We use a scoring tool called MAPS, and that asks them to rate their questions or rate their symptoms, and we use that throughout our program to kind of gauge if they're having improvement in symptoms. It's a little bit difficult with POTS to prognosticate because their symptoms can vary day to day, season to season, if they've recently had a viral illness. So part of what we try to talk to patients about is, number one, we understand that it's not just tachycardia, that there are many symptoms that go with this. And number two, there are going to be triggers that they might be able to prepare for or avoid. And there are going to be triggers that happen without their ability to avoid those, like a viral illness. So we try to set realistic expectations moving forward in terms of, we know you're going to do your best with what information you have, and there are still going to be days that you feel better and days that you feel worse. Most of the feedback that we get from patients is appreciation for listening and validating symptoms that are difficult to measure clinically, and then offering them resources moving forward. So it's a difficult thing to objectively measure, but subjectively, most people tend to feel better when they have more education and some agency over things to try when they're not feeling well.
Jen, would you like to add anything?
I think that really is the feedback that we're getting, that they are doing overall better because they are able to manage the symptoms better, even when the symptoms may be flaring, they have some ability to know what to do. Even if that is taking a rest day and not being able to go to work that day, they actually can have a notion of what they can do so that they don't have to take off 3 days. They may be able to attend to themselves for that particular day. And so it's been really a positive intervention. It's something that really, I think it has helped the team also feel like we are on the right track. And just the idea for our primary care community out there, as well as our cardiologists and our other referring providers, that they also feel that this has been a positive intervention. That has been a lot of good feedback as well, that their patients are coming back and appreciative that there has been some place where they could go to learn and, again, get this validation, as we keep on saying. I mean, we've been using that word a lot, but it's something it's a disease that they feel is frightening, and they feel like it's invisible because often they look normal, and and people don't believe them. And so this has been a really a good thing for our community and our community of providers as well, to support them.
Very good.
I agree. I think it's really frightening to have chest pain. And as lay people, we're advised that if we have chest pain, that we could be having a heart attack. And so we're going to go to the ER to get checked. And then you're told everything's normal. I think it can be really difficult to manage that emotionally.
I would say one more thing is that additionally, Molly's team has been connecting them also to other providers that they may not have known to get connected to because of the other manifestations of the autonomic nervous system issues. So to gastroenterologists, to sleep providers, to neurologists, rheumatology. There's so many comorbid conditions with this: migraines, Ehlers-Danlos syndrome, irritable bowel syndrome, mast cell activation syndrome. There's so many of these that then they could be getting connected with other providers who might be able to give them some relief from symptoms from another angle.
Yeah, no, I think you guys provided such a great overview on POTS today. In closing remarks, anything else that you would like to add in terms of resources that are already available for clinicians and as well as for patients?
Yeah, I usually use Dysautonomia International for my initial information, and I send patients there all the time. They offer an annual conference each summer, and they have a patient conference and a provider conference available, and it's a great place to start. University of Utah also has had conferences in the fall for autonomic dysfunction focusing on POTS, and that has been a great resource as well.
I would say that we appreciate having been given this time to explain this program, and we feel that perhaps maybe there will be others in the lifestyle medicine community who would be interested in standing up such an intervention, because as we were discussing, actually even before we started talking about this today, Molly and I were talking about, if you don't feel like you're seeing patients in your community right now that have POTS, it's probably because you're not quite aware of the condition of POTS, because the rise in the number of people out there with long COVID, we know they're there, and POTS is now affecting about probably 1/3 of those people. So there are individuals who need our help, and some of these interventions are doable, especially for those of us who are practicing lifestyle medicine. So thank you.
Yes, well said. Well, thank you, Jennifer and Molly. While we are out of time today, I really appreciate your time for sharing your passion and expertise with us. It's been a true pleasure having you join us today. Thank you to our audience for tuning into this episode of Flip Your Script. We hope today's conversation has inspired you with practical insights on how lifestyle medicine is shaping the future of patient care. If you enjoyed this episode, don't forget to like, subscribe, and leave a comment. Stay connected with us for more episodes featuring healthcare leaders and clinicians who are rewriting the script on health, one patient at a time. Until next time, take action, make an impact, and keep flipping the script on healthcare. Thank you.